And again, we like this model now in terms of thinking of it as a funnel. This doesn't quite look like a funnel. It still looks to me like two separate pathways coming into one. But if you think of it again as that circular, you're having two things happen at once. You're having the contact activation and the tissue factor. One doesn't really happen without the other. And if you have a lot of tissue factor, you can have some activation without having trauma, and those are those hypercoagulable people that we worry about getting strokes and things like that. And then you have the 12, the precalcarein, the 11, the high molecular weight proteins, 9, and then going down to eventually forming your fibrin clot. What I like about this particular one is that it gives you an idea. I'm not sure whether I have the next slide that I like to use in clinic, but it gives you an idea about the significance of your screening test. So the partial thromboplastin time is going to be across both intrinsic and common, so you can see which factors are involved there. Coagulation time, again, is across the board. Prothrombin consumption, so is going to be just through PT, okay? And then on the other side, you're going to have your prothrombin time through the extrinsic and common pathways, and then just a thrombin time looking at fibrinogen, and your fibrin sheet. So it sort of that helps you to see what's being measured when you draw those screening tests. So in more plain terms, the PT measures the extrinsic pathways, 7, 10, 5, 2, and 1. PTT, or the activated prothrombin, partial prothrombin time, measures the intrinsic pathway, and 12, 11, 9, 8, 10, 5, 2, and 1. So there's overlap, but at least distinctive things that you can look at and try and determine where the lack of factor is. So the first thing we do when these patients come to us with this non-bleeding history and prolonged PT-PTT is repeat it. And one of the reasons for that is that these are very unstable tests. And so when they sit in that blue top tube for a long period of time, that can affect your result. And so we are often arguing that we'd like to do these kids' times here where it's run in this lab so that the waiting time of running is less than an hour. Whereas when you go to LabCorp or Quest, those are lab stations where the blood is drawn. It sits there, then it's collected and taken to a central lab twice a day. So it could sit there, if you have your blood drawn at 7 a.m., it could sit there until 7 p.m. until it's run the next day. And often we'll get abnormal results sort of like in the middle of the night when they're running their next batch. That matters because then you can have an erroneous lag time, which is creating more time for that loop to happen and more activation. Thrombin time measures the activation of the fibrinogen to fibrin, so specifically fibrin is factor 1, nobody calls it that. Mixing studies. Mixing studies, what's done in mixing studies is that you have a prolonged PTT or PT, depends on what the abnormal study is. You take serum that has all the factors in it. You know it's normal and has the appropriate ratio of factors in it. You put it in. If that screening test is then rerun and it normalizes, you know there's a factor deficiency. For some reason, our lab reports it out the opposite of that, but that's what's actually done. So if you understand that, you'll get the basic idea. Bleeding time is no longer done because it's very difficult to standardize. Some places, especially in the adult world, will still cut you open and see how long you bleed for. The way that's done is there's a lancet that's usually done on the upper forearm. It cuts you, and then you have filter paper, and you get the blood from running down the arm, and you see how then you take the stopwatch and you see how long the bleeding lasts. That's great if it were controlled, but of course the way that you sop up the blood and the way that I do it might be a little bit different, and how accurate we are at that could be off by several seconds, which is the difference between a prolonged and a non-prolonged bleeding time. The reason that we stopped doing it is because that filter paper when you touch the cut, disrupts the clot, and then you can really do some damage. So if somebody really knows how to do a bleeding time and they never touch the actual active area of clotting, it's a good study to do, but not a lot of people are trained to do it. In my opinion, maybe my generation of fellows is sort of the last one where we learned how to do it. Certainly, I don't think any of the fellows can do it now. And you're going to run the applicable factors depending on the history, family history, and which screening test is prolonged. The notorious blue top tube, which needs to be filled up all the way. You do all your coagulation testing except for fibrin degradation products and bleeding time. It's citrated plasma. They came 3.2% of buffered sodium citrate, and it pulls 9 parts of blood to 1 part of citrate. The citrate chelates the calcium. So remember where the calcium was in that cascade? So it's chelating the calcium, it's taking it out so that coagulation cannot begin until the calcium is added back in. The citrate ion doesn't enter the erythrocyte, and consequently the citrate concentration is abnormally high when blood with high hematocrit is collected. So you also need a CBC when you're doing this workup because you want to know whether or not that's going to factor into your coagulation. And any platelet count should not affect your coagulation test. But a low platelet count will certainly affect your bleeding. Prothrombin time, you need to add tissue factor and calcium. It measures the rate of fibrin formation, again that factor 1. And PT will be prolonged with deficiencies in the extrinsic pathway and the common pathway. So 7 specifically if you have an isolated PT, and then your vitamin K dependent and your liver proteins are looking at with 10 and 5 and prothrombin and fibrinogen. It's used to detect factor deficiencies and monitoring of warfarin therapy. Partial troponin time, you add a phospholipid platelet substitute and calcium, and then it's going to give you the activated PTT. You're going to measure the rate of fibrin formation. It'll be prolonged if the intrinsic pathway is affected, 12, 11, 9, and 8. And the common pathway, again, 10 and 5 with your prothrombin and fibrinogen being your end products. Platelet substitutes are only partial thromboplastins, and they are incapable of activating the extrinsic pathway. PTTSA is used to detect factor deficiencies, screen for lupus anticoagulant, and monitor the heparin anticoagulation. We talked about this already. In the face of an elevated PT, a mixing study can be done to distinguish between factor deficiency and a circulating inhibitor. It's a 1-to-1 sample, and normalization indicates a clotting factor deficiency. So our lab, if it corrects, reports it as normal. That's where they get it. I don't get that because it just doesn't make sense to me that something that was abnormal and corrects is now normal. But that's the way they report it, and because they're saying, well, now it's normalized. So don't get confused. Most other labs, it will be reported as abnormal and sort of over. But you know if it corrects that you're missing factors, so you really do know what. And continued prolongation indicates that coagulation is occurring. Thrombin time is useful when both the PT and PTT are prolonged, so you don't need to do it as initial screening. You can do it as follow-up to try and narrow down your test. It adds thrombin to plasma, measures the rate at which fibrin forms. It's greatly prolonged by heparin, and it may be prolonged by qualitatively abnormal fibrinogen, so you'll need to also send for a fibrinogen. Inhibitors to the pathway include antithrombin 3, which is heparin binding protein, protein C, which is activated by thrombin and inhibits activated factor 5 and activated factor 8. Protein S is a cofactor, usually associated with protein C, and deficiencies of any of these can cause thrombotic disorders. Hereditary disorders of the fluid phase include hemophilia A, also known as factor 8 deficiency, hemophilia B, factor 9 deficiency or Christmas disease, von Willebrand's disease, hemophilia C, which is factor 11 deficiency, which has a variable bleeding history, so factor 11 deficiencies get a little complicated when all my preaching about taking a good history. Sometimes their bleeding is variable even for the individual. So sometimes they bleed and sometimes they don't, and that makes it really difficult to get a good bleeding history and know what's going on. In the hemophilias, our classic 8 and 9, there's 20 to 30% spontaneous mutations, so that you might not get a family history. There's both whether it's spontaneous or family history are going to be excellent. And then you're going to have the 3 levels of severity. A mild deficiency will have as little as 5% factor is considered a mild deficiency, up to 50, which 50 and above is normal. Moderate is 1 to 5, and then a severe hemophiliac would be less than 1%. You can't tell the difference in the bleeding by getting the bleeding history, so you need to do those studies. This is just a comparative of how the frequency of occurrence. Hemophilia A's tend to have more severe cases, whereas hemophilia B's tend to have more moderate cases. The diagnostics are what we already talked about. Factor 8 activity is measured by clotting or chromatic assay. Von Willebrand assay is used to distinguish between factor 8 deficiency and von Willebrand disease, and that von Willebrand, we don't have time, is going to look at factors and multimers. So you're looking at the weight of the protein in addition to just the factor 8, which you can have obviously an isolated factor 8 deficiency. And factor 9 activity is measured with the clotting-based assay. And then just quickly, the clinical manifestations of hemophilia. Severe obviously manifests itself a lot younger and usually less than 1 year of age. These are the kids that bleed at circumcision. Moderates will do at that toddler level, and then mild are usually from 2 years old to adult, depending on their activity and how high their percentage of factor is. In the neonatal period, these kids can have intracranial hemorrhages, and that's your real concern, and that's why knowing this antenatally is, or rather prenatally, is helpful, because we want to be able to prevent this kind of catastrophic bleeding. It's uncommon in moderate to mild, so you don't really have to worry as much, but certainly there are outliers, and again, you don't know what that maternal milieu is going to be like. Your hope is that during that traumatic delivery period, even if you're having a C-section, to sort of risk some of the mechanical risks of bleeding, it's still traumatic, and that initial bump in your factors is going to be helpful. And then you can worry about muscle and joint bleeds, which is obviously more significant and severe, but they can certainly have them with large traumas in mild patients. CNS bleeds are life-threatening, and is what patients, aside from complications of their treatment, patients with hemophilia die from. Post-surgical bleeding, they need to be compensated with factor for most surgeries, but patients with mild really need a less amount of factor to control bleeding, and sometimes don't need factor depending on how high they are. If they're up in the 45% range, some surgical procedures are going to require a ton of factor. And then oral bleeding is across the board that happens. I think we'll stop there, and we can get the rest of that on the server for you guys to finish up.